So the next topic for this session is role of pulmonary functions tests in clinical practice. And the speaker will be Dr. S K Pathak, who is the organizer of this program. He did his MBBS from GSBM Medical College in 1996 and DCH in pediatrics from the same GSBM.
Yes, 2 minutes, fast.
He did his MD in chest medicine from KGMC Lucknow. He did his work experience with ITRC Lucknow and research fellowship in KGMU along with Professor Rajendra Prasad. Presently, Dr. Pathak is running his own setup and he is the medical director and senior consultant with Breeze Easy TB Chest Allergy Care Center, Assi, Varanasi. Over to Dr. Pathak.
Thank you, sir. Thank you for nice introduction. Thanks and good evening to everyone. For a short notice, you have all present here. और हमारे सर गुरुजी भी हैं, डॉक्टर राजेंद्र प्रसाद सर, हमारे कोलिग्स भी हैं. मुझे बहुत अच्छा लग रहा है. वी आर जस्ट गोइंग completing the 11th conclave, the respiratory conclave. The topic is very simple because I want to tell something short, important things about the pulmonary function test. As we know, pulmonary function test to know the lungs function, how it's physically work, because the X-ray test, CT scan, everything will give the anatomical picture, but physiological picture will be by the pulmonary function test. And pulmonary function test especially includes many things. That spirometry is the most common, where the whole body plethysmography, single breath nitrogen washout, DLCO, peak spirometry, pulse oximetry, ABG, exercise testing, CPT. These are the component of pulmonary function test. The component of pulmonary function test, maximum inspiratory pressures, physiological testing during sleep, sleep study. And most common diagnostic tools is the spirometry we are using in daily practice. So, sir, spirometry is very important things. It's work like a ECG of lungs. Just we are just knowing the cardiac status ECG, where we just doing the ECG of lungs by the spirometry. The indication of spirometry is generally to rule out the diagnostic purpose as obstructive or restrictive lung disease, screen people to risk of pulmonary diseases. Assess the preoperative risk for surgeon is very important. Before any surgery, you have to advise the patient for pulmonary function test, especially to rule out any respiratory diseases in like COPD, asthma, any lung diseases. Assess the prognosis of the disease. Assess the therapeutic interventions. Assess the patient a part of rehabilitation program. It produces survey of the pulmonary diseases and to follow up the cases to monitor the treatment of bronchial asthma, COPD and anything, and evaluation of the impairment of lungs, identification of high risk groups like smokers and serial spirometry, occupational survey, and environmental hazard detection. So indications as a drug exposure related lungs diseases, pre-employment screening is very important for any employment, and physical fitness. We are just doing the spirometry, how lungs is working well. Indication in day-to-day practice to diagnose the bronchial asthma, assessment of severity and monitoring the response of treatment, detection of asymptomatic deterioration at home, the self-managed patient. Identify the trigger factors, occupational asthma, detection of COPD, evaluation of dyspnea. This is a procedure, something ATSM guidelines. We have to use a standard pattern for any spirometry test, because if spirometry doing not well mannered, then the report will be false. So in many restrictive patterns and obstructive patterns, there is some parameters be just down and some parameters are just up. So for the restrictive patterns, FBC always down, where the obstructive normal or maybe down, where the ABC always down, usually just down, and the AB on ABC is normal or low in the obstructive patterns, and TLC always down and normally high in the obstructive patterns. These are some flow curves for spirometries, where the spirometry the spirometry grading of asthma, just stage 1, stage 2, stage 3, stage 4, we just rate the based upon the predictive value of the buoyancy, and mild asthma persistent where the predicted value of variability is 20-30%, while stage 3, 60 to 80% of predicted value, and variability is 30%, where the severity of persistent asthma less than 60% of predicted value of less than 30%. Ambient values is generally less than 1 liter is a major impairment if you measure the spirometry ambient value. These are the some graphs presentation how we can identify something graphic presentation after bronchodilator, before bronchodilator, and normal is the flow rates of lungs volumes. Generally there are various lung volumes measurement, peak spirometry, force spirometry, maximum flow rate, P value, and tidal volume generally measurement, vital capacity of lungs, and force vital capacity generally the measurement, and force vital capacity in 1 seconds, residual volume as a measurement in the restrictive lung patterns, where FRC values measurement in restrictive patterns, and total lung capacity measurement. These are the graphic presentation where we just measuring the lungs volumes, many difference. Predicted normal values, and normal is a normal range is the 90% of the healthy normal population. Indians have lower values compared to the Westerns. North Indians have higher values than South Indians. The predicted value. Pre-test requirement is very important. Subject to be stand up high and sitting a posture straight, and ideally should be smoking stop before 24 hours, as well to ask the patient to last smoked at cigarette, consuming of alcohol at least 4 hours, and various exercises at least 30 minutes, wearing of tight clothes to avoided, and eating of substantial meals at least 2 hours prior to test. And this should be performed when the patient is clinically stable and free from any infection. So inhaled bronchodilators generally recommended withholding, short acting 4 to 8 hours, long acting 24 hours, anticoagulants is 6 hours, and oral short acting bronchodilators 6 to 8 hours, and sustained release beta 2 agonist 24 hours, theophylline 24/7, once a daily preparation 48 hours. The subject should be seated at approximately 5 minutes prior to the test, and should remain seated throughout the investigations. Should sit up of the right and chair with arms and backrest. The procedures, carefully explain the procedure to patients, and loosen the tight clothings, remove the nose rings, and ensure that he is sitting in erect posture. Apply the nose clip on the patients, and remove the loose dentures. The place of lips and teeth tightly around the mouthpiece. The patient should be instructed to breathe in a fully and possible, which he can do. Then to blow out the equipment as hard as fast as possible until the further gas can be exhaled. Must be at least 6 seconds and can be taken after 15 seconds. The patient should perform minimum 3 attempts. At least 3 attempts should be taken for spirometry. The results reported should be at the largest value achieved from the 3 technical acceptable tests. The difference between the values should be at least less than 5% or 100 ml. The measurement of slow vital capacity is also many procedures just doing short time, we just cannot explain. Important things is the criteria for acceptable of any report. Rapid rise of the SART and test until the peak flow is reached. The maximum effort maintained throughout the procedure. No sudden cessation of flow. Maximum inspiration effort so that the curve is rejoined the point is maximal inspiration. At least 3 acceptable reversible attempts should be tried. Error in the measurement is always the leak around the mouthpiece, a poorly coordinated SART test, and early termination of flow, and the flow gas coughing, cough free, and the expiratory effort was the submaximum, unable to obtain. These are some graphic presentation common problem in the flow volumes. The measuring reversibility airflow obstruction, they measure the degree of reversibility flow obstruction performed. The spirometry before the 10 to 15 minutes before administration of beta 2 agonist Beta agonists are generally considered the benchmark for bronchodilator. Bronchodilator response to increase the baseline FB1 after bronchodilator at least 12% or 200 ml. Dose of bronchodilator should be used of 400 microgram salbutamol or both anticholinergics. Repeated test at 10 to 15 minutes. And when they do resolubility test, the high resolubility and exclude the asthma. The contradiction very important. No apparent absolute contradiction, relative contradiction, hemoptysis always divided, pneumothorax, unstable cardiovascular status, recent myocardial infarction, thoracic abdominal cerebral aneurysm, anesthesia vomiting should, they are contradiction. Recent eye surgeries, recent surgery, thoracic abdominal should be avoided contradiction. The complication generally syncope, dizziness, pneumothorax, chest pain, coughing, bronchospasm. Infection control measures should be always take care of this. This is the some graphic bronchodilator response generally as just told previously. The PFT test indicate the risk of the post-operative common. For the surgeon is very important. FB1 is less than 2 liters, FB1 less than 40% of predicted value, FB1 212 less than 200 liter per minute, MAB less than 50%, ABG, PCO2 is less than more than 45% is a risk factor for the patient for surgery. So take home message for this topic is the PFT is the major physiological diagnostic tools to know about the lung function. Like ECG, by PFT we can diagnose obstructive respiratory lung disease, screen people of the pulmonary disease, assess the pre-operative assessment, to assess the therapeutic intervention, assess the patient as a part of rehabilitation program, epidemiological survey. So the summary as here very important thing is pulmonary function test indicator for pre-operative is very important. If we are just going for any surgery for surgeon, FB1 is very important, PCO2 is very important, spirometry is not perfect, then we have to avoid the surgery. Thank you so much. Thank you.
Thank you, Dr. Pathak, for this lucid lecture on spirometry. If anybody has got any question, Dr. Pathak is ready to answer.
Okay. So I would like Dr. Rajendra Prasad sir to present bouquet and anguvastram to Dr. S K Pathak sir. I would like chairpersons also, Dr. Rajendra Prasad sir, to present anguvastram and memento to chairperson sir.